Assalamualaikum warahmatullahi.
Waalaikumsalam, Doktor.
Boleh boleh dengar? I think we can start.
Alright, Doktor. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Welcome to our seminar tonight. So I will be the first presenters for tonight presentation. So my topics given is acute gastroenteritis and also dehydration. So this is the outline for my presentation. The first one is definition of diarrhea. The second one is etiology of acute gastroenteritis in children. Next is pathophysiology of secretory and osmotic diarrhea. The fourth one is clinical features of dehydrations. Next one is investigation, management, and also complication of acute gastroenteritis and also dehydration. So before that, we need to know what is the definition of gastroenteritis first. So gastroenteritis is the inflammation of the stomach and also intestines. And basically the hallmarks for patient with gastroenteritis is increase in stool frequency with alteration of stool consistency. And dehydration means loss of body water. So back to our first learning outcome tonight. So the first learning outcome is definition of diarrhea. So diarrhea can be divided into two, which is acute and also chronic diarrhea. So basically acute and chronic classified according to the days, according to the duration of loose stools episode. So acute diarrhea means abrupt onset of 3 or more loose stools per day and lasts no longer than 14 days. And chronic diarrhea means an episode of loose stools that lasts longer than 14 days. So the difference between acute and chronic is the duration. So next is the etiology of acute gastroenteritis in children. So it also can be divided into three etiology or causes. So the first one is virus. So the first and the most commonest virus for that can cause AGE in children is rotavirus. So it basically occurs in winter months and affects children at the age between 6 months and 2 years. And as you can see below, that is the picture microscopically of the rotavirus. The next one is adenovirus, specifically the strain of 40 and 41 adenovirus. Next is norovirus, or known as Norwalk virus. Next is coronavirus, astrovirus, and last one is pararotavirus. For the bacteria, so we can divide it into enteroinvasive and also enterotoxigenic. So basically, the enteroinvasive is the symptoms. Usually, patient comes with bloody diarrhea. So the most commonest organism, the most commonest bacteria that can cause enteroinvasive or bloody diarrhea, the first one is Campylobacter jejuni. The next one is Shigella, Salmonella, Enteropathic, E. coli, and last one is Yersinia pestis. The next one is enterotoxigenic that can cause watery diarrhea. So basically, the first one is Vibrio cholera, or we can say that the rice water stools of the Vibrio cholera bacteria. So the next one is enterotoxigenic E. coli, Bacillus cereus, Clostridium perfringens, and also Clostridium difficile. The next one is, and the last one is Staphylococcus aureus. So for the parasite, there are some that can cause acute gastroenteritis in children. The first one is Entamoeba histolytica, Giardia lambia, Cryptosporidium species, and last one is Cyclospora cyatanensis. So we go to the next next learning outcome. So the first one is about the secretory diarrhea. So diarrhea usually occur when intestinal fluid output overwhelms the absorptive capacity of the gastrointestinal tract. So here I just want to highlight the difference between secretory diarrhea and also the osmotic diarrhea. So as we can see from the picture, secretory diarrhea usually occurs due to release of toxins that bind to the specific enterocyte receptor that cause a release of the chloride ions into the intestinal lumen and leading to the secretory diarrhea. So basically, it will involve the enterotoxin by the bacteria and involve the cyclic AMP, increase in cyclic AMP that cause inhibition of the absorption of the sodium and chloride, and stimulate the release secretion of chloride into the lumen. So next is the osmotic diarrhea. Osmotic diarrhea usually occurs due to damage of the villus brush border of the intestine that cause the malabsorption of the intestinal contents and leading to osmotic diarrhea. So basically, this occurs because of impaired absorption of the gastrointestinal tract. Okay, I think that's all for the pathophysiology. Next is clinical features of different types of dehydration. So basically, we can divide dehydration into three types. The first one is isotonic, the second one is hypertonic, and the last one is hypotonic. So isotonic, basically, we can see that water is equal to sodium. Means that nothing is lost between water and sodium. For hypertonic, usually water is more than sodium. For hypotonic, water is less than sodium. So for the plasma osmolality, usually normal in isotonic, increase in hypertonic, and decrease in hypotonic dehydration. So for the serum sodium, usually normal in isotonic, increase in hypertonic, and decrease in hypotonic. For the thirst, usually for the hypertonic patient, a hypertonic dehydration patient will increase thirst. So for skin turgor, it will reduce skin turgor in isotonic patient, and not loss of skin turgor in hypertonic patient, but there is much loss of skin turgor in hypertonic patient. So for mental state, usually for isotonic patient, they will become lethargy or irritable. For hypertonic patient, it will become very irritable, and usually for hypotonic patient, it will become lethargy or and at very worst state, it can cause coma. So shock is very common in hypotonic dehydration or hyponatremic dehydration, and very uncommon in hypertonic dehydration. So next is about the investigation and also the expected result for the investigation in acute gastroenteritis patient. So the first one, for the investigation, we can divide it into three. The first one is blood investigation, stool investigations, and other investigations. So the first one for the blood investigation, so we can order for full blood count to see for a leukocytosis in the patient with bacteria, in the patient with infection. The second one, we can order for blood urea, serum electrolyte, and also creatinine level. This is for dehydration and also electrolyte imbalance. So basically, patient in AGE will have hypo or hypernatremia and hypochloremia because of the secretion of chloride into the lumen. So that it will cause reduced level of chloride in the blood. So not only that, we can also observe for blood urine nitrogen and creatinine proportion. So basically, in severe dehydration patient, it will have disproportionate high in patient with severe dehydration. The third one is serum bicarbonates, and basically it will low in patient with metabolic acidosis. The next one is the last one is random blood sugar. It will cause hypoglycemia in patient with poor oral intakes. Next is stool investigation. For the first one is stool for rotavirus antigen. For example, for the infection of rotaclone. The next one is stool culture and sensitivity. For patient with infection of Salmonella, Shigella, Yersinia, and Campylobacter, stool red cells and leukocytes if the patient are having bloody diarrhea, and stool ova and cysts if the patient expected for having parasite infection. So the last one, for the others investigation, we can order for arterial blood gas to check for metabolic acidosis and urine osmolality. Basically, in dehydration patient, it will increase the urine osmolality. Next, for the management, we can plan for 3 plans. So plan A, plan B, and also plan C. So the first plan is plan A, treat at home. So what should the caretaker know about the first plan? So the action need the first action is give extra fluid to the child. The second one is continue feeding, and when to return. So the first one is give extra fluids as much as the child can take. So we need to tell the mother they need to breastfeed frequently and need to breastfeed for longer for one time. So if exclusively breastfeed, we need to give oral rehydration solution or cold boiled water in addition to breast milk. If the child not exclusively breastfeed, give oral rehydration salt, food-based fluids, or cold boiled water. So the next one is continue feeding. If the infants or the child are breastfeeding, we need to continue breastfeeding. And if the infants or children is formula fed, need to continue with usual formula. Okay, so for the last one, when to return. When to return means when to go to clinic or hospitals to seek for any treatment or management by the general practitioner or medical officer. When the child is not able to drink or breastfeed or drinking poorly, the child becomes sicker and develops fever. And the last one has blood in stool. So next one is treat with oral rehydration solution. So what we need to know as a doctor, we need to have an action as we need to give an appropriate amount of oral rehydration solution that is correspond to each over 4 hours of period. So for this thing, you can refer to the PITS protocol for the better understanding. Next, we need to reassess the patient after 4 hours. Last one is we need to treat severe dehydration quickly. So we need to assess the airway, breathing, and also circulation very quickly. And we need to resuscitate the patient. We can start intravenous or intraosseous fluid immediately. If the patient can drink, we can give oral rehydration solution by mouth. And we need to set up a drip also. I think that's all for the management. So the last one is for the complication. So there are several complications that we can see in patient with acute gastroenteritis and also dehydration. So the first complication we can see from the renal complication. So usually patient will have oliguria. Oliguria here means that the patient will urinate less than 200 milliliter per meter square per day.
200. Yes, continue, madam.
Less than 200 milliliter per meter square per day or 0.5 milliliter per kg per hour. If a patient have pre-renal acute kidney injury, urine osmolality need to be more than 500 milliliter, and urgent intravenous volume re-expansion is needed. So the next one is hypovolemic shock due to increased secretion of water. Next is electrolyte imbalance, basically sodium and also chloride. And next is metabolic acidosis, renal venous thrombosis, basically will comes with hematuria and also renal mass. And the last one is hemolytic uremic syndrome. Basically, we can see the patient with hemorrhagic colitis by the E. coli, and it will have acute onset of microangiopathic hemolytic anemia, thrombocytopenia, acute renal impairment, and involvement of the multi-system. Next is upon the CNS, not CVS, but CNS. So CNS will have convulsion due to hypernatremia, hypoglycemia, and it can cause febrile convulsion. It caused due to electrolyte disturbance and usually associated with Shigella infection. And the last one is for the gastrointestinal tract. it will cause prolonged diarrhea. That can be chronic in nature. That is more than 14 days. I think that's all for my presentation. Thank you.
What organism causes secretory diarrhea? You did not mention your presentation just now. What organism commonly causes secretory diarrhea?
Secretory diarrhea, Vibrio cholera.
Okay, Vibrio cholera. Well, the osmotic diarrhea are usually other organisms like E. coli. Okay, all right. Continue with the next presentation.
Thank you, Doctor.
Assalamualaikum warahmatullahi wabarakatuh. Now I will continue with the second topic, which is the bronchopneumonia. So my name is Aida Fariha and with metric number 10946. So this is the outline from for my presentation, which will start with definition, etiology, the pathogenesis, the clinical features, investigation and management, and then lastly the complication. So for the introduction, as for definition, pneumonia means the infection of the lung parenchyma with the consideration of the alveoli, in which it happened due to the infiltration of the tissue with the existence of the inflammatory cells. So for bronchopneumonia, is the inflammation of the lung parenchyma that arises from the bronchi and bronchiole, and is usually accompanied by the inflamed patches in the nearby lobule of the lung. So as you can see from the picture, this is the patches of that presented in the bronchopneumonia. So a little bit about the epidemiology. So this is the largest infections that cause death in child in worldwide, and usually the pneumonia peaks in infant. And in Malaysia, about 28 to 39.3% of the child below 5 years old are affected with pneumonia. Caused by infection from the virus and bacteria. So in all younger children, the most common causes is from the viruses, while the older children usually caused by the bacteria. However, it is very difficult for us to distinguish between the viral and the bacterial pneumonia in the clinical practice. So as I provide below, which is the table with the basically in this the causes is streptococcal group is streptococcal E. coli, Klebsiella, and then there is Enterobacteria. So usually for the neonates, pathogen is transmitted during the interpretum from the mother genital tract. And then next is the infant and young children, which is usually caused by the viruses instead of and then, but it also can caused by the bacteria. And then lastly, in the older children, which is contrast with the infant and young children, the bacterial infection is more common than viral infection. So this is the list of the possible infection that can get by the children. So next is pneumonia. So for the pneumonia, it happens when there is a failure of the self-defense system, as it will be difficult as if there is failure of the self-defense, so it will be difficult for the immune system to protect the host. So the first example that cause the inhibition of the resident is the inhibition of the resident alveolar macrophage phagocytosis, in which the macrophages are not phagocytosis of any particles. Then another example is the other immune deficiency patients, such as HIV patient or malignancy patient. So as we know, in this patient, the immune system is impaired, so they cannot brush off the microbe that enter the airways. Next is the repress of the cuff reflex. So actually the cuff reflex is very important in us as it helps to expel the foreign particles in the airway. Therefore, if the cuff reflex is repressed, it means that the microbe, the pathogen will stay in the airways and cannot be expelled out. And lastly is the mucociliary impairment. So as we know, the epithelial lining in our airways organ have cells that are called goblet cells, in which this goblet cell will secrete the mucus, and then this mucus will trap the foreign particles. And then we also have the cilia that function to brush off all the foreign body in the airways. So when any of these defense mechanism is failed, so the host becomes susceptible. Therefore, the bacteria and the virus can easily go into the airways, and then they will infiltrate into the alveoli and then will proliferate. So this will trigger and activate the immune system, in which later lead into inflammation of the alveoli. So this inflammation process can cause injury towards the alveoli, and then it will lead to the leaky alveolar wall and then pump capillaries. And then due to this, alveola will be filled with fluids and pus, in which it will lead to the consolidation of the alveoli. And then lastly, as the complication, the alveoli will be filled with the fluid and pus, and then it will decrease the exchange of carbon dioxide and oxygen, in which it means that the gas exchange is impaired. And so that's why the patient will come with rapid ventilation of breath. So next we continue with the clinical features. So for the symptoms, patient pneumonia will usually come with cough and runny nose, which happen because of the body trying to counterattack the microbes that come into the body, and then they can or not have fever, but fever usually happen due to the inflammatory response, and then in most cases they will become short of breath. They have rapid and shallow breathing and become lethargic and restless. This happen due to the accumulation of the fluid and pus that I said just now around the alveoli, with gas exchange process. And then lastly, the pleural irritation. The pleural irritation happen when due to the pleural inflammation. So due to this pleural inflammation, patient will have the pleuritic chest pain, abdominal pain, and neck stiffness. So for the abdominal pain, usually it occur if there is involvement of the lower lobes of the lung, while the neck stiffness occur when there is of the upper lobe of the lung. So that's the sign or what we expect to see in the physical. So for inspection, basically we will see the sign of respiratory distress like the grunting, increase of breathing, air hunger, tachypnea, cyanosis, and intercostal retracted. So and then in palpation, we will see that the chest movement or the chest expansion will be decreased due to the difficulty and painful for the child to breathe. And then there also will be increase of tactile parameters due to the inflammation of the lung tissue. And then on the percussion, there will be dull instead of resonance due to the presence of the fluid in the pleura. And then lastly, on auscultation, it will increase the breath sound, the bronchial breath sound, and then we will hear the cross crepitation. There will be a pleural rub, which is it's kind of like raspy breathing sound, and then it will also increase the vocal parameters. So next, I will move to the investigation. So first, we can do a full blood count. So in full blood count, we will focus on the white blood cell. So in white blood cell, if there is increase of the predominance of polymorphonuclear cell, it will suggest that the patient might have bacterial pneumonia. However, if the patient is having leukopenia, so it suggests that it might be due to the viral pneumonia or due to the overwhelming infection. Next, we can do the blood culture. So for blood culture, usually we've done in the severe pneumonia, or when there is poor response towards the first line of antibiotic. It is actually the non-invasive gold standard to determine the causes of the pneumonia. However, it has low sensitivity. And then next one is the serological test. So serological test usually will be performed in a patient with suspected of atypical pneumonia because this bacteria that cause atypical pneumonia like Mycoplasma pneumonia, Chlamydia Legionella, and Morazella can cause are difficult to be found through blood culture. So that's why we are suggested to do the serological test instead. So next is the pulse oximetry. So for pulse oximetry, we need to assess the severity of pneumonia as we can measure the level of the hypoxia from the children. So next is the chest radiography. So from the picture, this is the multinodular or reticulonodular opacity. As in the bronchopneumonia, there will look like a patchy opacity in the lung, at the lung. And then lastly is the pleural fluid analysis. But for this pleural fluid analysis, usually we will done if there is significant pleural effusion from the patient. So for management, usually for patient with pneumonia, we manage according to its causative agent and symptoms, but not all cases need to be hospitalized. So for the criteria of hospitalization, the child must be aged less than 3 months, and then they have high fever, which is more than 38.9 degrees Celsius, and she might like refuse to eat and then vomit, which cause next is the if the patient having fast breathing, and then if the patient have the recurrent pneumonia but fail with the and then severe underlying disorder. So for management, we actually have two, which is the pharmacological and then the supportive management. So for pharmacological, basically we will give the antibiotics to the patient, and then this is first line, second line, third line other agent. For the usually we will start the second line of antibiotic when there is no sign of recovery and patient remain toxic with spiking temperature for 48 hours to 72 hours. So in this case, we will start the second line antibiotic, and then the table below, it is the common agent, antimicrobial agent that we use for certain pathogen. So, and then this is the supportive treatment. For supportive treatment, first is fluid. So in pneumonia case, we need in severe pneumonia, there will be increase of ADH secretion. So to make sure that the child is over dehydrated, so we need to withhold the oral intake. And then the second one is the oxygen. So we need to maintain the we need to give the oxygen to maintain the SpO2 to make sure it's above 95%. And then we will give this oxygen if the patient appear restless, tachypnea, we are having a severe chest indrawing, cyanosis, and they're not tolerating with it. And then we can also do the chest physiotherapy in order to assist in the removal of tracheal secretion, tracheobronchial secretion. So in this chest physiotherapy, we will remove the secretion, so we can remove the airways obstruction, and then by remove this airway obstruction, we can increase the gas exchange and then decrease the work of breathing. And then we can lastly is temperature control, as we can use paracetamol to decrease the discomfort or decrease the temperature for the patient. So lastly, regarding the complication for bronchopneumonia. So first one is the parapneumonic effusion, which is the accumulation of fluid in the pleural space. And then this accumulation of fluid in the pleural space, if it's being untreated and for a long time, the pathogen will like invade into the pleural space and stay there. And when the pathogen like bacteria stay in the pleural space with the pleural fluid, the pleural fluid later can develop into empyema, which is passed in the pleural cavity. And then pneumonia also can cause a lung abscess, as in severe pneumonia. It can cause tissue necrosis, then we later develop into lung abscess. And then lastly, the most dangerous one is the septicemia, in which when the bacteria start to invade and disseminate in the bloodstream, and then cause the sepsis to patient. So I think that's all for bronchopneumonia.
Or it's vital again, a basic clinical examination. Just want you to be alert again about the type of auscultation on respiratory system. Recall again, when we talk about vesicular breathing, okay, vesicular breathing is a normal breath sound that you heard where inspiration is longer than expiration. This is normal breathing. If you put your stethoscope on your chest now, and you breathe in and breathe out, normally, this is what vesicular breathing, okay? So it is normal. Inspiration longer than expiration. So in bronchopneumonia then, most commonly that you have actually a reduced breath sound, or you used to say a reduced air entry. Fadil usually don't really like, most respiratory patients don't like to use air entry. So one other way of seeing it is actually the breath sound. So most common in pneumonia is actually the breath sound you hear is actually abnormal. Why abnormal? Abnormal usually one side usually will be reduced. Okay, so breath sound is reduced on one side. Okay, right or left, or is it reduced bilaterally? Right. So based on that, you can actually evaluate whether this child has right or left pneumonia or bilateral pneumonia. Right, then other additional sound like crepitation and rhonchi is additional information. But more information, more common is actually a reduced breath sound, okay, rather than increased breath sound. Quite rare we use the word increased breath sound. I mean, of course, yes, we see why we see increased breath sound, but I mean, I have never come across represent increased breath sound. Increased breath sound means that when the child is already receive some form of treatment, you know, there's some area of infection has improved over the bad one, that some area you hear the breath sound increase. Okay, but early phase, usually in your exam, most patients they will see will be reduced breath sound on certain part, either one side or bilaterally. Okay, so fix to this one. If you say vesicular, means that inspiration is longer than expiration. So in this situation, I think later we go to bronchiolitis and asthma. In this case, you can't say vesicular, especially if they are wheezing, right? Wheezing cannot be vesicular. Some of you, when a patient has asthma or bronchiolitis, then you present to the examiner on auscultation, so vesicular breathing, while the child is having acute wheezing. Cannot lah. Because by definition, vesicular means inspiration longer than expiration. Understand? Must be very clear about this concept of vesicular breathing and what you want to present when child has wheezing. All right, okay, we move on to the next one.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nurhanisa binti Arifin. So I'm going to proceed the presentations on the acute bronchiolitis. Okay, so what is actually mean by a bronchiolitis? It is a disease of the small bronchioles with the increase of a mucus production. And due to this, it can sometimes have occasionally bronchospasm and sometimes can lead to the airway obstruction. So why it is important for us to know about the acute bronchiolitis? Because it is one of the most common serious respiratory infections of infancy. So it actually, acute bronchiolitis became a leading cause of hospitalization in infants. And it's also important for you to know that acute bronchiolitis is almost exclusively during the first 2 years of life, where about 90% of them are aged about 1 to 9 months. Okay, so these are actually the list of causes of acute bronchiolitis in children, where most of it is actually caused by virus. And the most common virus that can cause acute bronchiolitis is respiratory syncytial virus, RSV, where statistically it compromises about 80% of the cases. And other virus that can lead to the bronchiolitis is parainfluenza virus, rhinovirus, adenovirus, coronavirus, and also human metapneumovirus. And sometimes bronchiolitis also can cause by bacteria, which is Mycoplasma pneumoniae, but it's actually very rare. And you should acknowledge that a viral bronchiolitis is highly infective. So the mode of transmission for the acute bronchiolitis is through the infected secretion. So this is when the children come into contact with the infected respiratory secretions when their surrounding is not, for example, not practice a good hand hygiene. So it's also possible for the child to be infected in such a crowded housing area or in a daycare. Okay, next we will proceed on the pathophysiology of the acute bronchiolitis. So for the pathophysiology of the acute bronchiolitis, the first thing is the causative agents that I've mentioned earlier, which is the most common is HSV. Initially, we colonize the nasopharyngeal mucosa. So as we know that our respiratory airways is divided into two, either is upper respiratory and lower respiratory. And we know that nasopharyngeal is our upper respiratory airways. So when it first colonizes the nasopharyngeal mucosa, it will cause the upper respiratory airways mucosal inflammation. So when there is a lot of inflammation and lots of things going on there, so protein and fluid leak into the nasopharyngeal interstitium, and this will lead to the coryzal symptoms. So that's explain why in patient with acute bronchiolitis, the first symptom will be a coryzal symptom such as a nasal congestion or nasal discharge. So for about 1 to 3 days, the virus will travel via the epithelium to the lower respiratory airway, and it will eventually reach the bronchioles. So when it reaches the bronchioles, it can lead to the bronchiolitis. So which is inflammation of the bronchioles. So it will stimulate the upregulation of the mucus secreting goblet cells. This will lead to the increase in the mucus production. When there are lots of mucus production, the airways, which is the bronchioles, will become narrower and occluded. So this explains why the patient might have difficulty in breathing and coughing and others. Okay, so this is actually just the difference between the normal bronchial tubes and bronchial tube during the bronchiolitis. Just like I mentioned earlier, there is a mucus build-up, and then associated with the inflamed tissue, and also there is a necrosis and loss of epithelium that can lead to the smooth muscle tightening, which is a bronchospasm. Then this can make the bronchioles become narrower and become occluded, and like there is a blockage of it. Okay. Okay. So we will proceed on the clinical features of the acute bronchiolitis. So as I mentioned, actually I have mentioned a little bit of the clinical features of the acute bronchiolitis on the pathophysiology earlier, where usually in early symptoms, the patient, the children will develop a coryzal symptoms such as a nasal congestion and discharge, and also a mild cough. This is because as the HSV, the virus will initially colonize the nasopharyngeal mucosa first. So the patient also can have a low-grade fever, which is less than 38.5 degrees Celsius. And then later, when about 1 to 3 days, when the virus has colonized or go to the lower respiratory tract, then the patient might have a shortness of breath, persistent cough, and noisy breathing, and even it will lead to the apnea. Okay, so during examination, what kind of findings that should be expected in the bronchiolitis patient? So the first one, of course, we start with the inspection. So during inspection, we can see that bronchiolitis patient can have can be tachypneic, and you can also see there is a subcostal and intercostal recession, just like the picture that I've attached there, which is show the example of intercostal recession. So why intercostal recession happen is because when there is a blockage in the airways, and this will actually lead to the reduced air pressure inside the chest, and as the result, the intercostal muscle will be sucked inward between the ribs when the child breathing. So the third one, during inspection, you can is it possible to see nasopharynx, where the nostril will be widened during breathing, just like the picture I've attached with there. The difference between the normal nostril and also flat nostril. And then next, during percussion, you can the findings that you might expect is a hyperresonance, and also during auscultation there is a reduced air entry, high pitch wheezing, and also prolonged expiration. Okay, next is investigation. So for bronchiolitis, actually the routine lab tests are not required to confirm the diagnosis. So in fact, the diagnosis of the acute bronchiolitis is mostly based upon a history and as well as the physical examination that I just mentioned earlier. But the most important things to be done is, first one is to monitor the oxygen saturation by using the pulse oximeter. This one should be performed in all children with suspected bronchiolitis. So the second one is the chest X-ray. For your information, chest X-ray is also not routinely required, but recommended in children with severe respiratory distress and those who came with the unusual clinical features. So what do we expect from the chest X-ray in the bronchiolitis patient? There will be a lungs hyperinflation and as well as a flattened diaphragm. And the third one is the ABG, which is arterial blood gas. Arterial blood gas is important to check the level of oxygen and also CO2. But again, it is not routinely done and only done in the severe cases. Okay, so this is example of the findings in the chest X-ray with the patients of bronchiolitis. As I mentioned earlier, there is hyperinflation of the lungs. There is a flattening of the diaphragm and also an increase in the hilar bronchial markings. Okay, next we move on onto the principle of management. So actually, principle of management, in order to manage the acute bronchiolitis in children, it is actually only a supportive therapy. Where the first one, we go for the respiratory monitoring, just like I mentioned earlier, which is we use arterial oxygenation by the pulse oximeter, where the arterial oxygenation should be maintained above 93%. And sometimes in the hospitalization patient, we can administer supplemental humidified oxygen by nasal cannula if necessary. And the second one, as the patient with the bronchiolitis also can develop fever, we have to control the fever by using acetaminophen, paracetamol, or ibuprofen. And then the next one is nutrition and food therapy. Nutrition and food therapy is actually for the children with feeding difficulties. And the last one is infection control measure. For the infection control measure, as I mentioned earlier, that viral bronchiolitis is highly infective. So it is very important to practice a good hand hygiene and cohort nursing in order to lessen the spreading of the disease to the other patients. And you have to, and then based on, you have to know that there is actually the lack evidence of benefit from the use of the mist, nebulized hypertonic saline, antibiotic, corticosteroid, and also bronchodilators. Okay, so this is actually the guidelines for the hospital admission in the viral bronchiolitis. And as you can see there are several criteria need to be achieved in order for us to decide for the hospital management. For example, those who age less than 3 months, and then you see the patient is having a toxic looking, and then you see from the inspection, the chest recession is very severe, and then you can inspect that there is a central cyanosis, and then it also has a difficulty in feeding, and then the patient also already developed apnea, and the oxygen saturation is less than 93%. And if the child is included in the high risk group, those are the criteria that need to be managed, need to be admitted to the hospital. Okay, next we go for the complications of the acute bronchiolitis. So actually one of the major concerns for the complication of bronchiolitis is apnea. So apnea is this frequently occur, especially in the very young patient, a very young infant. And as I mentioned earlier, that mostly acute bronchiolitis occur in the about 2 to 9 months infants, right? So it is very crucial for close monitoring for the patient in this age group. So the other complication can be secondary bacterial infection, asthma, and also bronchiolitis obliterans. So for asthma, actually the incidence of asthma somehow seems to be higher for children that has been hospitalized for bronchiolitis as infants. However, it is actually still unclear whether this is a causal or whether the children prone to asthma are more likely to hospitalize with bronchiolitis. And then for the bronchiolitis obliterans, it's actually a very rare to that as a complication of a bronchiolitis. And although if it happens, it is mostly associated with adenovirus rather than RSV earlier, as mentioned earlier. Okay, and then for the prognosis, you should know that the most cases of the acute bronchiolitis, it will resolve completely within 2 weeks. And mostly, hospitalized children will show marked improvement in 2 to 5 days only with a supportive management as mentioned earlier. And then, however, about 50% of patients will have a recurrent episode. Okay, I think that's all from me. Thank you.
All right, very clear, very good. We take a short 2-minute break, then after that we'll start back with the last presentation. Okay. All right. Okay, whenever you're ready, we can start back.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay. Assalamualaikum. Assalamualaikum warahmatullahi wabarakatuh. Next, I will present you about bronchial asthma. My name is Nabila Muhammad Isri, number 118. So, alamak, tak gerak. Lagging. I'm sorry, Doctor. I think I So, I present to you about bronchial asthma. Next. So, the outline for my presentation. First, I will explain to you about definition, then the pathophysiology of bronchial asthma, key features, history taking, expected finding, then investigation, principle of management, and complication of asthma. Next. So, definition of bronchial asthma is there will be a chronic airway inflammation that lead to increased airway responsiveness that eventually leads to recurrent episodes of wheezing, breathlessness, and coughing, particularly at night or early morning. Chronic airway inflammation can also cause chest tightness. It's often associated with widespread but variable and reversible airflow obstruction, either spontaneously or with treatment. Usually, asthma is reversible. And the physiological triad for asthma is reversible bronchial muscle spasm, mucosal edema, and increased mucus production. As you can see in the picture, the asthmatic lung usually have the muscle tightness of the bronchial that will lead to narrowing of the bronchial. Next. Okay, this is a brief pathophysiology of asthma. As we have learned before in our preclinical years, asthma can cause by genetic predisposition, atopy, and environmental triggers. And atopy is basically individuals who readily develop antibodies of IgE class against common environmental antigens. They basically, and usually this atopy individuals have other diseases like eczema. And asthma can also be caused by environmental triggers such as upper respiratory tract infection, allergens like house dust mite, grass pollen, spat, smoking, active or passive, pollution, and chemical irritants like paint aerosols. Like we have learned before, the union of the allergen, the environmental triggers, with IgE bounded with histamine can result to production of leukotriene and histamine. And histamine can cause bronchial inflammation. The bronchial inflammation cause edema, excessiveness of the mucus production, and cellular infiltration. Histamine and leukotrienes can also cause bronchial hyperresponsiveness, where there will be exaggerated twitchiness to inhale and physical stimuli like cold air or exercise. This results to reversible airway narrowing, where there will be bronchoconstriction and airway inflammation. Eventually, patient with asthma will have symptoms like wheeze, cough, breathlessness, and chest tightness. Next. Sorry, doctor. Sorry, doctor, there's technical problem.
Can it be sorted ke? You boleh apa, kalau tak boleh, can you email your slide to one of your colleagues cepat? Boleh kita buka depan ni.
Yes,
Cuba.
I'm trying to send it to my friend. So, asthma can result to clinical features like cough, shortness of breath, wheezing, and chest tightness. Next. Okay, for history of asthma, first, we need to identify and elaborate the chief complaint for the shortness of breath, for example, where if the shortness of breath occurs episodic, diurnal, like during the day, after or during exercise. And then we also need to ask further questions to rule out other causes of shortness of breath. For example, the pandemic that occurs right now is COVID-19, right? And COVID-19 can cause shortness of breath. So we need to ask further symptoms to rule out the disease. For example, shortness throat. Soreness of throat, runny nose, and fever of breath. So we need to ask the patient and other causes. Okay, next. We need to ask for symptoms that indicate severe or life-threatening acute exacerbation of bronchial asthma. If we need to ask if the patient can speak in words, have altered mental status, have poor breathing effort, and we need to also explore the cause of this current exacerbation. Example, if this patient have been exposed to respiratory infection, if the patient is non-compliant to medication, if the patient have asthmatic attacks because of exercise or exposed to allergens, or if this patient have asthmatic attacks when exposed to cold temperature. We then also need to clarify the diagnosis of the asthma. When was the diagnosis made? What is the presentation the diagnosis of the asthma? If the patient have other symptoms like cough, shortness of breath, wheezing, and chest tightness as I have mentioned before. If the patient and we need to also summarize all previous episodes of shortness of breath prior to the diagnosis made. And we need to ask if there is any investigation done. And other than that, we need to also ask for the risk factor of the asthma, like if there's any family history of asthma, atopy, personal history of atopic disorder like eczema and allergic rhinitis. And we also need to ask the severity of the disease will be estimated, and if there is any previous exacerbation or admission to FTU or ICU, or if there is any intubation before. And you need to ask about the control of disease. If there is daytime symptoms more or equal to 2 times per week, night awakening, exercise-induced symptoms, or need to use reliever more or equal to 2 times per week. If there's any interval symptoms, current treatment for the asthma and impact of the disease to biopsychosocial. For example, if the patient misses school days because of asthmatic attack. Okay. Next is the expected finding for the patient. First, general expression, we find that if there is signs of respiratory distress for this patient, next vital signs, increased respiratory rate, pulse rate, and decreased partial pressure of oxygen. And for patients that have complicated with pneumonia, they can have increased temperature. And for anthropometry, any failure to try the if the patient have any flattening tremor, as that indicate carbon dioxide retention. If the patient have fine tremor, because the fine tremor can be a side effect of beta agonist. And we also need to look for if the patient have eczema. And for the ANT examination, we can see for if the patient have otitis media, because usually otitis media can influence the developing immune system and can result and patient can have asthma. And we need to look for if the patient have allergic rhinitis, because allergic rhinitis have the same substance that can cause asthma. And for the throat, we can look for evidence of URTI, because URTI can cause asthma, and cervical lymphadenopathy. And because cervical lymphadenopathy can cause by infection that caused by the allergen. For the respiratory examination, we can look for the Harrison sarcai, as you can see in the picture. Ada picture ada black ground. You can see that it's Harrison sarcai. If the patient have barrel chest, reduced chest expansion. Okay, on auscultation, we need to look for if the patient have reduced breath sound, prolonged expiratory phase, bronchi, and corresponding with pneumonia. And we need to look for evidence of hyperinflated chest, loss of cardiac dullness during palpation. So when palpate, the cardiac have lost their dullness, and if there is palpable liver and increased anterior posterior diameter of thorax. Okay, for the diagnosis, usually for patient less than 5 years old, usually we'll look for the history taking and physical examination. The investigation are not really looking for, but usually it's more important for the history taking and physical examination. As you can see in the purple table, there is the probability of asthma based on the symptoms, like if there is duration of the symptoms, cough, wheeze, heavy breathing during URTI is more than 10 days, that means the patient has high probability of asthma. And then we look for the number of exacerbation, and then interval symptoms between episode or exacerbation. If the patient have cough, wheeze during play, during laughing or exercise, then the patient might have a high possibility of having asthma. And if there is family history of asthma or atopy present, then there is high probability of asthma. And other than that, from other sources, it also sees that for usually patient, it's normal for baby to have like wheezing. So we need to explore more about the symptoms of the patient. For the positive index, we can see in the black table. If there's more 3 wheezing episodes per year during the first 3 years, plus 1 major criteria or 2 minor criteria, then you can see this positive highly possibility that the patient have asthma. For example, if the patient have more than 3 wheezing episodes per year during the first 3 years, and the patient also have eczema, then we can see the patient have high possibility of having asthma. Next for the
Terima kasih.
investigation.
Tak sos.
Sorry, Amila, I think your mic.
What happened to
Okay,
background noise?
next,
Bising.
Mila. Next
Apa
for
punya
the
background noise tu? Apa dah kau ni? Siapa punya background noise cakap tu? Kawan tu?
Next for the investigation, we can look for the lung function test, laboratory investigation, imaging and other investigation. So first, for asthma, we can look for lung function test, we can do respiratory flow rate and spirometry. And spirometry is to monitor response to treatment, assess degree of reversibility with therapeutic intervention, and measure the severity of an asthma exacerbation. And usually FEV1 FBC ratio is less than 80%. As you can see in the picture, the green one is the normal result of spirometry for non-asthmatic patient, and the black one is before, and the black one is before, and black one is before, and the red one is after using medication, using after administration of salbutamol. As you can see, that is the result of spirometry. Other than that, we can also do bronchodilator reversibility, where they will be showing an improvement before and after a dose of inhaled bronchodilator, where it will be more or equal to 12% in FEV1 improvement. Other than that, we can do exhale nitric oxide concentration is marker of airway inflammation. It will be elevated in untreated asthma and allergic rhinitis. For laboratory investigation, we can do fluticasone and natriuretic blood gas test that can reverse hypothermia, and it's important in status asthmaticus, one of the complications of asthma. For imaging, we can do also chest X-ray, but chest X-ray is usually not done for diagnosis of asthma. Usually, it's just to exclude other causes of shortness of breath, and also to exclude anatomic abnormalities. Other investigations that can be done is using skin prick test that to identify the allergens that cause allergy. Next. Okay, for principle of management, first we assess asthma severity or newly diagnosed asthma. Then we choose preventive treatment and assess asthma control again in 4 to 8 weeks. Then we do stepwise medication and monitor asthma control. Next. Okay. First, we evaluate the newly diagnosed asthma. If the asthma is intermittent asthma or persistent asthma. If the asthma have symptoms less than 1 per week, then we can say that it's intermittent asthma. Look for the nocturnal symptoms that's equal to per month or not exercise in the symptoms. And brief exacerbation not affecting the activity that is intermittent asthma. For persistent asthma, we can divide it into mild, moderate, and severe, where the severe have daily symptoms and might have the daytime symptoms more equal 1 per week, nocturnal symptoms more than 2 per month, and have FEV1 more than 80%. There will be exercise or activity in this asthma. This also for you can see the severe, they have daily symptoms, daily nocturnal symptoms, and have FEV1 less than 60%. Then we can also see for the assessment of severity of acute asthma exacerbation for children. We look for the parameters. If the patient have breathless when walking, at rest or apnea. If the patient have breathless, if the patient talks in sentences, phrases, words, and unable to speak. And you can see if the patient unable to speak, it might be life-threatening acute asthma exacerbation. Acute asthma exacerbation. If the asthma, if there is increased respiratory rate, then that means it's severe, it's more severe. Then we need also to look for any presence of fees, partial pressure of oxygen, pulse rate. Next. So you can see for the long-term management of asthma, for intermittent asthma, we give intermittent short-acting bronchial and you can also give low dose inhale corticosteroid for mild persistent asthma. As you can see in the small table at the bottom left, you can see there's the ICS, inhale corticosteroid, beclomethasone, budesonide, fluticasone, and cyclosonide that can be used for the patient. For patients with moderate persistent asthma, we give moderate dose of inhaled corticosteroid 200 to 400 mg per day, and for severe persistent asthma, we give moderate dose of ICS 400 to 800 mg per day combination therapy or high dose ICS. For severe persistent other asthma, they give moderate dose ICS combination therapy and SLRA or high dose ICS combination therapy 800 to 1,200 mg per day. Next is a complication of asthma. Asthma first can cause pneumonia. As you know, asthma can cause chronic damage to our lung and can easily expose the patient to pneumonia. The patient can also have pneumothorax, where if the asthmatic patient usually have upper inflated lungs and they have bronchospasm, so there will be increased pleural pressure that can cause the formation of flap. And if the flap are ruptured, then there is a pneumothorax. And other than that, patient can also have lung collapse, where if the air are get out from the lung into the area between the lung and chest wall, it can result to increased pressure and the lung can shrink. The last one is status asthma can cause status asthmaticus, where there is an acute exacerbation of asthma that does not respond adequately to therapeutic measures and may require hospitalization. And it can range in severity from mild to life-threatening, so it's very important for us for if the patient has asthmaticus that we send for hospitalization. I think that's all from me. I'm sorry for the technical problem.
Okay, all right. Just a short comment. Lung function test in pediatric, we don't use it. Number one is because, especially for younger children, because they won't be able to use the lung function test to blow out, to expire. So it's good for research, maybe for adults as well, and older children. But most of the time we use clinical history and clinical judgment, right? So another one that you can use is actually pre and post SNAP. Pre and post nebulized peak flow, PFR. There's another one yang usually it's easier to use in older children. Again, younger children, they can't blow the peak flow meter. Okay, any question related to the all the presentation? Quite clear. Got no specific comment. I think it's quite clear. All right. So, any question?
So far, no, Doctor.
Alright, okay. Kalau tak ada, kita end up dengan tasbih kafaratul salat. I'll give you the marks to the group leader. All right. Okay. Assalamualaikum warahmatullah.
Waalaikumsalam. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.